from the platform of the Women in Cardiology and Related Sciences. I'm Dr. Sunita Kumbhalkar, Professor from AIIMS Nagpur. Today, I will be talking about the ESC trials, various trials which are presented at ESC. One is a NOACH AF-NET6 trial. This trial was with the objective of investigating the efficacy and safety of oral anticoagulation in patients with AHRE, that is atrial high rate episodes, but without ECG documented atrial fibrillation. The study population was patients more having AHRE episodes more than equal to 6 minutes detected by implantable devices, plus additional stroke risk factor like heart failure, hypertension, diabetes, prior stroke and transient ischemic attack, vascular diseases, and the age was more than 75 years. In about 18 European countries with 206 sites, it was conducted. About 2,536 patients were enrolled, and patients were given edoxaban as anticoagulation and no anticoagulation. But this group is then given aspirin 100 milligram once daily as an indication for the antiplatelet therapy was there. The primary endpoints were composite of stroke, systemic embolism, and cardiovascular death. So it occurred in about 3.2% per year in the edoxaban group as compared to 4% per year in no anticoagulation group. Safety outcomes, again with the edoxaban group, it was 5.9% per year, while 4.5% per year in no anticoagulation group. And the difference in safety outcome was driven by an expected increase in the major bleeding with the edoxaban group. So the conclusion, blood thinners, that is anticoagulants, cause bleeding without preventing stroke in patients with atrial high rate episodes, but without ECG diagnosed atrial fibrillation. So what is the impact on clinical practice? The results clearly suggest to demand ECG documentation of atrial fibrillation prior to the initiation of the oral anticoagulations. Second trial is advanced reperfusion strategies for patients with out-of-hospital cardiac arrest and refractory ventricular fibrillation, that is ARREST trial. This is a phase 2 single center open label randomized control trial. The study has 36 patients assessed for eligibility. The 6 were ineligible. Total 30 were enrolled and then they randomly assigned. 15 assigned to the ECMO facilitated resuscitation and 15 were assigned to standard ACLS treatment. One patient refused to continue. So 14 were included in the primary endpoint analysis in the ECMO facilitated resuscitation, while 15 included in the primary endpoint from the other group. So here we can find there was a statistical difference, significant benefit seen in the ECMO facilitated resuscitation. So the primary outcomes, that is a survival to the hospital discharge, was seen in 43% of the cases in ECMO facilitated group, while it was 7% in a standard ACLS group. The other secondary outcomes also, like survival to about 6 months and 3 months, was also significantly better in the ECMO facilitated resuscitation group. So this is the again chart showing the different parameters like survival in a ECMO group, which was better. Then the modified ranking score and the cerebral performance score were also the other trial is a safety of switching from a vitamin K antagonist to a non-vitamin K antagonist oral anticoagulation in frail older patients with atrial fibrillation. This is the result from the frail AF randomized control trial. So in this trial, again, they've studied about the cumulative incidence of the major bleeding or clinically relevant, even non-major bleeding event. So the authors clearly find out that the VK group also had a lesser bleeding risk as compared to the NOAC. So the patients who were switch over from the conventional oral anticoagulation VKA group to the NOAC like dabigatran, rivaroxaban, apixaban or ridoxaban. So its study favors the control group as compared to the intervention group. And this benefits of the study has a major impact that without offsetting any increase in the thromboembolic events. So there is definite increased bleeding risk after switching over to the newer anticoagulation. The other study is the STOP DAPT 2 ACS randomized clinical trial. The comparison of clopidogrel monotherapy after 1 to 2 months of dual antiplatelet therapy with 12 months of dual antiplatelet therapy in patients with ACS. So this trial was in patients with acute coronary syndrome, and after initial 1 or 2 months of the dual antiplatelet therapy, they were continued only on the clopidogrel for a 12 months period. So various primary endpoints and the major secondary endpoints were studied, and here the you can see that the cumulative incidence with a 1 or 2 months of DAPT and 12 months of DAPT, it was lesser with a only the single agent if the clopidogrel is continued. So the major secondary bleeding endpoint was, you can see here, definitely you get the decrease in the bleeding risk. Secondary bleeding endpoint was definitely decrease in a clopidogrel given only for initial 1 or 2 months of dual antiplatelet therapy and the continuation of the clopidogrel only in the another 12 months period. Similarly, for the definitive and probable stent thrombosis also, you can find the cumulative incidence of the probable stent thrombosis was less with a therapy with the clopidogrel, even if it is a single agent given at the end of 12 months. The HEART FID study studied the efficacy and safety of ferric carboxymaltose as a treatment for heart failure with iron deficiency. This was also a double-blind, multicenter, placebo-controlled, randomized trial. The objective of the study to assess the effect of the ferric carboxymaltose administration on safety and outcomes in patients with the heart failure. About 3,065 patients were studied with the inclusion criteria: patients with iron deficiency with the ferritin less than 100 nanogram per ml or 100 to 300 nanogram per ml with transferrin saturation less than 20%. Heart failure with reduced ejection fraction less than 40% on maximally tolerated GDMT, and heart failure hospitalization within the last 12 months or NT-proBNP more than 600 picogram per ml. So about 1,532 patients were given weight-based infusion of FCM and another 1,533 patients given infusion of saline as a control. So you can see the primary endpoints here: the hierarchical composite of mortality, heart failure hospitalization, and change in 6-minute walk test distance all favored the treatment with the treatment arm, that is with FCM. The secondary endpoints also, the mortality was reduced and hypersensitivity or the anaphylactic reactions were increased with FCM 7 versus 1 patient. So the conclusion of the HEART FID study: in patients with iron deficiency and HAPREP, treatment with FCM was safe and resulted in improvement in the endpoints of mortality, heart failure, hospitalization, and the 6-minute walk test. Another study in the lipid management with coronary artery disease is a lodestar study. The study design was a patients with coronary artery disease. About 4,400 patients were studied with 1:1 randomization design. The rosuvastatin treatment arm has 2,204 patients, while atorvastatin treatment was in 2,196 patients. The clinical follow-up was at 3 years with a composite of all-cause death, MI, stroke, and any coronary revascularization. So at the end of this period of about 3 years, you can find either rosuvastatin group or the atorvastatin group. There was not much difference. It was statistically non-significant regarding the cumulative incidence of the primary outcome. So here you can see primary outcomes of death, MI, stroke, and the coronary revascularization. There was statistically not significant in both the groups. So both the treatment can be given in patients with acute coronary syndrome as a long-term treatment. So regarding the reduction in the LDL cholesterol in the Lodestar trial, you can see better reduction was there with the rosuvastatin group as compared to the atorvastatin group. The next is a STAFE AF trial. It was the results were presented by Mikhail Kosiborod from the St. Luke's Mid-America Heart Institute, USA. This was a multicentric trial from 13 countries. About 529 patients with heart failure with preserved ejection were studied with a BMI more than 30 kg per meter square in a 1:1 randomized design. Here they studied the semaglutide GLP-1 agonist 2.4 milligram or a placebo for a period of 52 weeks with the primary outcome from change from the baseline in the Kansas City Cardiomyopathy Questionnaire clinical summary score and mean percent change in the body weight. So already the blood sugar decreasing effect of the semaglutide we know. So secondary outcome where the physical function, mean change in 6-minute walk test and changes in inflammatory markers. So what were the results? There was a greater improvement in KCCQ CSS score from 16.6 with semaglutide versus 8.7 points with placebo. This difference was statistically significant. In exercise function also, semaglutide fared better in terms of greater weight loss and greater reduction in the inflammatory markers. The semaglutide fared better. Serious adverse effects were significantly more common in the placebo group. So, the study concluded with improvement in the heart failure related symptoms, inflammatory markers, and the physical function. They represented big potential for the clinical benefit in patients with the heart failure. QUEST trial. This is a late-breaking double-blind QUEST trial in a patient's which contains a mixture of 11 herbs, including milkweeds, root, ginseng, and this was studied in about 133 hospitals across the China and the Hong Kong. So, about 3,100 adults with HAPREP with the LBF of less than 40% with the NT-proBNP more than 450 picogram per ml in a 1:1 randomized design. The drug was quiliquiaxin 4 capsule thrice a day as compared to the placebo group. This drug was added in addition to the standard of care drug in the chronic heart failure. So primary outcome, which was a composite of readmission for worsening heart failure or cardiovascular death, were significantly less common than in the placebo group. P was significant. The quiliaxin, this drug was well tolerated, but there was no substantial difference between the study group in terms of the adverse effects or all-cause deaths. So, study concluded from author Jinli Li from Nanjing. So, this finding demonstrates meaningful clinical benefit with the drug quiliquianzin, and it can support its use as an adjunct therapy in standard of care treatment with patients of the worsening heart failure. Another study with the ECLS shock study. This is a multicentric randomized control trial. About 420 patients with AMI with cardiogenic shock were included. So either ECLS with standard of care treatment or standard of care treatment alone. The primary outcome was all-cause mortality at 30 days. The results of the study were neutral. There were no difference in primary outcome. All-cause mortality occurred in 47.8% in an ECLS group and 49% patients in the control group with a hazard relative risk of 0.98 and p-value was not significant. There was increased risk of moderate to severe bleeding and peripheral ischemia in ECLS patients. So concluded by presenter Holgi Theli, University of Leipzig, Germany, there is no benefit of ECLS in this group of patients with AMI presenting in a cardiogenic shock. The multi-stars AMI study, presenter was Barbara Istaheli from University Hospital of Zurich. It was an open label trial, randomized trial. Aim of the study to determine whether immediate complete revascularization at time of primary PCI was non-inferior to stage, that is 19 to 45 days multi-vessel PCI. It was in a 37 sites in Europe in patients of STMI having multi-vessel coronary artery disease. The patients of cardiogenic shock, left main disease, previous CABG, CTO were excluded. It was 1:1 design. The immediate PCI patients were about 418, while stage PCI was done in about 422 cases. So, primary endpoints, which was composite of all-cause death, non-fatal MI, stroke, unplanned ischemia-driven revascularization, or hospitalization for heart failure within 1 year. It was a non-inferiority study. So, immediate group has a 8.55% and the stage group as a 16.35% events. The non-fatal MI and the ischemia-driven vascularization were more common in stage group. There was no difference in all-cause death, stroke admission to hospital for heart failure. So, conclusion of the study, immediate PCI of non-culprit lesion is as effective and safe as a stage procedure. So, this is a major decision from the study. The study in a cancer patient with DVT occurring in these cases is a onco-DVT study. This is also a multicentric open-label trial. Presenter Yugo Mashita Koeto from the University of Japan. The patients of cancer who developed DVT, they were included. About 296 patients in 12 months developed and about 305 patients developed DVT in 3 months. So, primary outcome was studied at we studied the patient at the 12 months and at the end of 3 months. So, primary outcome was symptomatic recurrent VTE or VTE related deaths were studied. Secondary outcome, major bleeding at 12 months. The results of the study, so 1% in the 12-month group and 7.2% cases in the 3-month group achieve primary outcome with the odds ratio of 0.13. Secondary outcome were present in 9.5% versus 7.2% in cases. So, it was concluded 12 months of edoxaban, that is an oral factor 10A inhibitor, is superior to 3 months for the reduction of thrombotic events in the cancer patients presenting with the deep venous thrombosis. The last trial, which was the imaging trial like of OCT in patients of complex bifurcation lesion, is an October trial. This was the first adequately powered clinical trial to examine whether routine use of OCT during the PCI of complex bifurcation lesion improves the clinical outcome compared to standard angiographic guidance, optional use of the IVUS. Here, about 1201 patients across 13 European countries were studied. Female also has a good representation of about 21%. So, primary endpoint MACE were seen at the period of 2 years, including composite of cardiac death, target lesion MI, ischemia-driven target lesion vascularization. So, the findings were 10.1% of the OCT group and the 14.1% in angiographically guided group had the primary events. So, the conclusion of the study, PCI guided optical coherence coherence study reduces the adverse cardiac events in patients with bifurcation lesion. So it is better that the PCI is guided by the OCT as compared to the conventional angiography, which is SOS I was guided. So these are the all the new trials which were presented in the OCT, including some lipid trials, imaging trials, patients of drug trials in the ACS patients, and the clinical trials in heart failure patients, in elderly patients. So thank you, the WINCARS, for giving the opportunity for presenting the newer trials on this WINCARS platform. Thank you.